Greetings and welcome to the Lurie Children's Pediatric Bariatric Surgery Virtual Roundtable. My name is Chad Worley. I am your moderator for today, which is Session 1, Nutrition Considerations for Children and Adolescents Undergoing Bariatric Surgery. Your presenter today is Lurie Children's nutritionist, Emily Hobbs, and she'll be introduced to you today by Lurie Children's Chief of Surgery, Dr. Thomas Inge, who's also the program head for our pediatric bariatric surgery. Before we get started, I'd like to remind you that this session is being recorded and will be available to view on the Lurie Children's Physician Services YouTube channel. And if you enjoy this, I encourage you to share it with your colleagues and to like it. And I'd also like to remind you to please remember that no CME credits are being given for this session today. But I'd like to let you know that today we are brought to you, Emily Hobbs will be our presenter today. And she is, like I mentioned, she is Lurie Children's registered dietitian for the bariatric surgery program. But I'd like to also introduce you to Dr. Thomas Inge, who's our chief of surgery. Dr. Inge, welcome this morning. Thank you for joining us.
Thanks, Chad. Really appreciate the opportunity to talk to our provider community, our PCPs and pediatricians that are interested in obesity and bariatric surgery. I'm Tom Inge. As Chad mentioned, I'm the surgeon-in-chief at Lurie Children's Hospital and also direct the bariatric program here at Lurie Children's in the Streeterville campus. I'm really pleased to welcome you to this roundtable because it is an important topic to me, and I know that your time is important to you, and we're grateful that you've taken time out of your schedule to be with us today. I think it's important to understand why we're hosting these roundtables. First, we would really like to help the broader pediatric community to better understand where adolescent bariatric surgery fits into the care of young people that are struggling with severe obesity. Many of you care about these patients and see these patients from time to time, and you may not be aware that surgery is an appropriate treatment option, along, of course, with lifestyle interventions and increasingly pharmacologic interventions within a comprehensive package. And I think that's what our program really has strived to offer and does offer. So we also see these sessions as a way to share practical and evidence-based perspectives from our own Lurie providers. Today, we'll hear about nutrition, but we also have medical as well as surgical and behavioral health domains that we focus on. And I think we can bring that information to you in this format. We are intentionally designed as a multidisciplinary program. You will, again, meet some of the characters, our program members, in other words, Karen Mangarelli as our medical director, Alyssa Williams as our NP, Emily Hobbs, today you'll meet as our dietitian, and Kelly Lowry is our program psychologist. We all come together and really together in a multidisciplinary clinic, allowing the team to come to the patient rather than sending the patient to multiple other different offices for input and consultation and approval. I'm really proud to introduce Emily Hobbs, who has been with us for years now and focuses not only in her job on bariatric patients and how we can counsel to manage obesity and get weight down, but is also actually a member of our general dietary team and also helps with failure to thrive babies in the hospital. So she has a very broad practice. Her talk, entitled Nutritional Considerations for Children and Adolescents Undergoing Bariatric Surgery, is a topic that is aimed at giving practical considerations and practical advice. So we will certainly have time for a Q&A afterwards. I'd love to stay, hear the talk myself, and be there at the end for the Q&A. And we'll also have a very special announcement at the end, too, about a symposium that we're planning in May. So without further delay, let me pass the microphone to Emily Hobbs.
Thank you, Dr. Inge. Thank you, Chad. Good morning. I'm Emily. I'll just jump right in so we can get started. The objectives of this presentation. So I want to just quickly talk about nutrition considerations related to obesity as a disease, as well as nutrition considerations related to bariatric surgery specifically. I have a few pearls to share for obtaining accurate dietary information from our patients, And then we'll just review nutrition needs pre and post-operatively as well. So just as an overview, in the US, there's an estimated 14.4 million children with obesity. Severe obesity is obesity that's defined as a BMI at or above 120% of the 95th percentile. 4.5 million adolescents in the US qualify for that diagnosis. And this category of children or adolescents is growing faster than the rate of obesity otherwise. So we call that an epidemic within an epidemic. So this is a really important problem that a lot of people are dealing with, and especially a lot of our children are dealing with. Obesity has been associated with micronutrient deficiencies for a number of reasons. One being the excess adiposity that these people have. The theory is that the vitamins get trapped in the excess adiposity, specifically the fat soluble vitamins, so A, D, E, and K. And then they're not able to be converted to their active form. They're not able to be used as cofactors, coenzymes, the way they should be. It's also associated with poor diet quality, diet histories that have a lot of fast food, a lot of fried foods, a lot of convenience, ultra processed foods, and low in fresh fruits and vegetables, whole grains, lean proteins, things like that. And then relatedly, the social determinants of health are going to impact a person's weight status as well as their micronutrient status. So people at a lower socioeconomic status are more likely to have obesity, in part because they're unable to access fresh, healthy foods in addition to other things. So diet and exercise, obviously extremely important. I care a lot about people having a healthy diet and exercise lifestyle, but alone we find that those interventions result in about a 3 to 5% weight loss in the most successful individuals, whereas something like a sleeve gastrectomy surgery can result in 30% weight loss. Definitely meaningful. Diet and exercise is so important. It makes a person healthier, but it doesn't necessarily meaningfully change a person's weight the way that surgery can. Next slide. Okay, so nutrition considerations. Protein, the most important thing that we talk about this at every single visit. Our main goals are to prevent catabolism, deconditioning, prevent sarcopenia. We really want to maintain lean body mass in these individuals. This is just going to keep them baseline healthy, keep their immune system healthy, prevent injury. But most importantly, it's going to increase their basal metabolic rate, which is really important when we're thinking about weight management. So we encourage 60 to 90 grams of lean protein every day, split into 20 to 30 gram meals and snacks. Any higher than 90 grams is really just going to give excess calories without any additional benefit. You know, in pediatrics, we think of everything in per kilo. So 90 grams, we divide that per kilo for some of these patients is going to be really low, but 60 to 90 grams is going to be enough to prevent catabolism, maintain lean body mass, and promote weight loss at the same time. Fluid is another thing that we really emphasize. So these are beverages that are not carbonated, not sugar sweetened, and not caffeinated. One of the main reasons for readmission, just large scale, is dehydration. So we encourage a minimum of 64 ounces of those hydrating fluids daily. Again, per kilo, that's low. So really just whatever we need to prevent signs and symptoms of dehydration. As far as calories go, this is not something that I personally share with the patients. This is for my documentation and assessment. I use resting energy expenditure with a very low activity factor of 0.5 to 0.8. If you're familiar with those activity factors, normally we're using like 1.3, 1.5, 1.7. So again, low. Post-operatively, this is appropriate to maintain nutritional status and promote weight loss at the same time. Micronutrients, so important. I have an entire slide coming up to talk about that in detail, but this is going to be a lifelong recommendation that we give to the patients. For physical activity, the general guidelines apply. So 60 minutes or more daily with an emphasis on muscle building activities. This is important really to consider, obviously, the age of the patient. The younger kids are not going to be going to the gym and lifting weights. They might rather be in karate or play soccer or something like that. And then encouraging the entire family to do these things together. So can the family go on a bike ride together? Can they go for walks or play games or have dance parties? Can they do that together? And then just a note that for patients using GLP-1s, these nutrition interventions are very similar. So we still want to prevent catabolism. We still want to keep them hydrated. We still want them physically active, whether they elect to use the GLP-1s or surgery. Okay. So as I mentioned, micronutrients are very vital to prevent micronutrient deficiencies. After surgery, they're on a very strict and restricted diet. So they're not getting the same diet variety for the first 3 or so months after surgery, but their portion sizes are also very small. So they're limited in their micronutrient intake after surgery. So everybody needs a multivitamin with iron. I prefer the bariatric brands because the formulations are a little bit more specific to this patient's needs. So Bariatric Fusion, Celebrate, Bariatric Advantage are some of my favorites. However, these are expensive and can be hard to find. So we can use an over-the-counter multivitamin like Centrum and just double it. We add 100 milligrams of vitamin B1 to everybody's vitamin routine to prevent beriberi. In our clinic, we give vitamin B12 intramuscularly every 6 months, starting on day of surgery. Alternatively, the patients can take that orally daily. I think it's easier to get a shot every 6 months, so that's what we do here. For calcium, everybody needs 13 to 1500 milligrams in divided doses. So the body really can only absorb 500 or 600 at a time. And then that needs to be separated from any iron containing vitamins, again, for maximum absorption of both iron and calcium. For vitamin D, this is one of the ones that everybody's low in. It seems like the multivitamin does contain all the vitamin D that they need at baseline. But if we need to replete, then we'll replete vitamin D based on those guidelines. And then we routinely screen for micronutrient deficiencies after surgery just to make sure that the vitamin routine is working and do we need to make any changes. Okay, so just an overview of the diet progression for surgery. I think this is where our patients are most intimidated, or one of the ways that they're most intimidated. So the liver reduction diet is to reduce liver volume. We do this here for the 2 weeks prior to surgery. I've seen other programs go up to 4. And then post-operatively, we have a 3-month texture modification diet that slowly reintroduces texture and food groups to promote healing and weight loss. So that's listed there. That varies institution to institution, but this is what we do here at Lurie. The post-operative diet is way easier than the preoperative diet. The stomach is the same size, appetite's the same size preoperatively, so they really struggle with that. But after surgery, not only is their stomach smaller and they're getting full with less food volume, but those hormonal signals creating hunger are not there. So post-operatively is much, much easier, even though it doesn't seem like it. Okay. Some nutrition pearls. So I know you only have maybe 5, 10, 15 minutes to get an accurate, thorough recall. It's really important, especially in obesity management, to build rapport, build trust, get the family to trust you, meet them where they are, reinforce positive behaviors. Sometimes the families, they come in so proud of themselves for a change that they made. And then I have to tell them that change actually wasn't as healthy as they thought it was going to be. But I try really hard to still reinforce and praise the effort because we really want to keep motivation high. Obesity is a hard disease to manage, so we want to keep spirits as high as we can. Ask for details using open-ended questions. So try to avoid, obviously, yes or no questions. Use visual aids to assess portion sizes. So a palm size portion, it's about 3 ounces of protein. That's going to be about 20 grams. So that's a 1 meal portion size. So showing the patient the palm of your hand, asking the patient to show you the palm of their hand can just help, make it less abstract what you're talking about. Similarly, a fist-sized portion of rice is about a cup. That's about a serving size. Ask about sides, ask about seconds. Sometimes people forget to mention the bread rolls or the tortillas or the extra things that kind of come with their meal. So ask about those things specifically. Ask about drinks. If you can, ask, is it diet or regular? Do you get anything from the vending machine? Did your friend give you something? Did you take something off your friend's lunch tray? Because these things can add up and people don't always consider them as part of their meal. Asking about eating in secret, waking up in the middle of the night to eat, or eating at unscheduled times. Sometimes if I ask, do you eat breakfast? The patient says no, but then later I find out that they didn't have a hot meal first thing in the morning, so they didn't think that was breakfast, but they did have a donut or a granola bar or something like that. They're just not considering that breakfast. Asking questions as open-ended as possible, and then avoid leading the patient to a certain answer. So the example I put here, rather than asking, are you taking your multivitamins and calcium? Ask, which vitamins do you take and how often do you take them? You're quizzing them. It's really important to do all these things with like warmth and kindness and with rapport with the patient, because you're not trying to catch them in a lie. You're just trying to get the most accurate information. Next slide. Okay. And here are my references and some resources, some things that are helpful. Thank you all for tuning in. I'm happy to take any questions. But yeah, thank you for sharing some of your morning.
Emily, thank you. That was fantastic. Got a bunch of questions in here for you. And Dr. Ange is going to be some questions for you as well. So feel free to jump in. But Emily, for you, one of the things I wanted to ask you was, when I saw the protein intake, do you recommend, because sometimes it's hard to eat that much protein as a kid. So do you recommend a protein supplement as like a powder, or maybe one of those shakes that you can buy in the store that are the lower carbs but higher protein with a low glycemic index? Would something like that be beneficial?
Yeah, absolutely. I recommend those all the time. I like Premier, Fairlife, Muscle Milk. We actually require those post-operatively. So I do, at a minimum, ask the patients to at least taste test them. Yes, those are great. Those are great tools. I do warn the patients not to get too into them early
Right.
on, because there is going to be a time where they are only drinking protein shakes. So if
Mhm.
they know they're going to get sick of them, they need to ration them so
Right.
that they can still use them after surgery. But for a patient who is just maybe trying lifestyle modifications to lose weight, or someone who's being cared for by PCP, these protein shakes are a great tool to use. I do encourage real food sources first, like chicken,
Absolutely.
eggs, yogurt, but in a
Yeah,
pinch,
yeah,
they're a great tool.
You're right, Chad, to think about this. And I agree that real protein first, if it's appropriate for your time beyond surgery for that diet stage. Early after surgery, it's really liquid protein that we look at. And here again, I think the common sense of reading labels, and if words are more than a few letters long, that in particularly preservatives and so forth, that we try to stay away from those as processed foods. So
Right.
I think that pure protein powder, and there are some sources for it, are far better than the products that may be out there with just limitless numbers in this dieting craze society that are ultra processed. We'd stay away from those.
Yeah. With that in mind, with protein supplement in mind, for the patients that are exercising, you mentioned exercise and muscle building exercises for those who can do it. Would you recommend a branch chain amino acid or a creatine for any of them to help with that? Or is that just a little bit too young and away from that right now at this stage with supplements like that?
I can take that if you want, Emily.
Yeah, go ahead.
Yeah, so I don't think that the literature would support creatine in the postoperative phase for any particular enhanced endpoint. for our youth. The literature that I'm aware of does speak to a potential benefit from cognitive as well as muscle building and lean mass preservation, in particular for older adults, meaning the 50s, 60s, 70s crowd, for creatine in particular. So I just think that there is no real good reason to set parameters or restrictions or goals that are outside of the goals that Emily just articulated for the post-op bariatric population.
That makes a lot of sense to me. The other thing I wanted to ask you, Emily, is nutrition guides, writing down everything that they eat so they can do journals. I couldn't get it out this morning. Do you recommend journals for them to write down and keep track of what they're eating and what they're putting? It almost, this is what I'm doing, so it's my responsibility, and this is how I'm eating, and I can show it to my provider.
Yeah, good question. I don't like as general practice. I think like we want to create a lifestyle that's as sustainable and long lasting as possible. And I find with some patients, this just becomes stressful and overwhelming,
Yeah.
and they're likely to just give it all up.
And one
And
more
then addition,
responsibility for them, I bet, that they
just
don't need.
another thing to do.
Yeah,
Right.
and
So
Chad, I would just say too, when I'm evaluating a new symptom or abdominal pain or this kind of thing after surgery, I might do that for a select reason, working up something that seems like a new issue. But in
Yeah.
general, I agree that it's not, it just adds burden to the day. Once they get into the groove, if you will, and know what things that are in their diet, what the protein content is, the water content, and get them into a new lifestyle after surgery. I
Yeah.
try to just declutter their lives and not add things that don't add value.
I couldn't agree with you more. I think that's especially younger kids. They have homework and all these other responsibilities that they need to get to. You touched on water, Dr. Inge. Emily or Dr. Inge, do you have any tips for getting kids to drink more water and get into their diet? Because we all know that they miss that, right? Whether they're a patient of yours or they're just a regular kid, we know they miss their water unless they bring their water bottle with them to school.
yeah, I would say getting a reusable water bottle and carrying it around, especially for the younger kids, like letting them pick one out that has like their favorite characters on it, or letting them put stickers on it, making it their own. And then we do have to remind them they are kids. The parents have a role here to remind them. I find too adding some flavors. I don't love adding a ton of the crystal light powders and things like that, but a little bit to just help them, or putting frozen fruit in the water or cucumbers or something like that to make it fun and diversify it a little bit can help a little bit too. But yeah, I think making sure your kid has a water bottle that they like to use, that they can carry around. If your kid is 8, they're probably not gonna be able to carry around a 64-ounce bottle. They're gonna need a
Right.
smaller one. But yeah, give them some autonomy, let them decorate their water bottle, let them choose what fruit goes in, but then they also are gonna need to be reminded.
Sure.
But adding flavors can help, especially the sugar-free ones. And just practically, I generally encourage people to drink more plain water than the artificially sweetened flavored
Let's not get
waters.
reliant on it. Yeah.
A little bit is likely not going to be harmful. I'm personally pretty risk adverse, so I just tell them to drink more plain water than they do Crystal Light or Gatorade Zero or something
Sure.
like that.
That's great. You mentioned the age 8. So I want to transition a little bit our conversation to our bariatric program, pediatric bariatric program here at Lurie Children's. Can you start, maybe give us a little background on when a patient should be referred, ages, weight? Can we talk a little bit about that? Either one of you, please.
Sure. Yeah. So I was part of the original 2004 pediatrics guidelines for surgery. Back when I started doing this in 2002, we really didn't have any pediatric guidelines. We borrowed from adults. And this age question has been a source of real controversy over the years. We've deliberately not put in writing a lower age boundary for a few reasons. One, it's not because we really are at all targeting pre-adolescents for this kind of intervention, but rather we're wise to the world in that insurance companies will deny access to services and if you have rigid constraints. So on that one, knowing that some preteens do develop awful things related to their obesity, like type 2 diabetes and other comorbidities, we felt like it's really clinical practice and the multidisciplinary team's role to determine what patients are best for surgery in terms of that age question. Now, in the ensuing 22 years since we wrote the original guidelines, we have actually looked at that question of, is there harm, any greater signals of harm or benefit for preteen youth versus teenagers when it comes to bariatric surgery? And we haven't detected any signal for really better outcomes or any worse outcomes or higher frequency of adverse events in the preteens. In terms of our older age limit for the program, practically speaking, when kids are emancipated, if you will, or emancipate themselves from the family home, finish college, and start their own lives, they're out of our area of our age range, I would say, and they're referred on to adult providers, except with the exception of kids or patients with chronic childhood diseases where Lurie Children's is still their medical home, and these may be special needs kids and so on, that we would still consider our area of responsibility for their overall care.
Thank you so much. That description is really helpful because I'm sure that question is coming up a lot. Dr. Ange, I have a few more questions for you about the program, but before I get to that, Emily, we have one question that came in from Jessica Lee. She wants to know, how do the recommendations for vitamins and micronutrients change if the patient is not undergoing surgery?
That's a good question.
You're right.
For a patient not undergoing surgery, so do you mean like a patient with obesity who's pursuing weight management, pursuing
It's
weight
not
loss?
described in the question, but I'm going to assume yes, way it's raised.
Okay. I would say for a child like that, they're likely going to be able to adequately take in nutrients from their meals and snacks, that vitamins are not going to be totally necessary the way that they are for a post-operative patient. But just to cover all the bases, a teen multivitamin or a children's multivitamin would be appropriate for someone like that.
Okay, thank you. Back to our program and the bariatric surgery portion of it. Can you maybe talk a little bit about the benefits, or how does it help the bariatric surgery help those with type 2 diabetes?
Yeah, sure. This has been a topic it's been a focus of mine and my research team for a long period. What we see in plain terms is that type 2 diabetes reverses within usually 6 months. And the vast majority, say 90% of individuals with type 2 diabetes who are adolescent when they undergo the surgery. This reversal of diabetes is durable for 3 years. We've measured at 3 years this 90+% reversal. And then when we've looked further beyond 3 years, because that's a big part of the question, what's the durability of the response? We see that at 10 years, we still have 50% of those that had diabetes at baseline that are in remission. So we do consider diabetes a very difficult problem to treat. If the results at 10 years, if we've lost essentially half of the patients who have undergone a relapse of some sort, I will hasten to say that when we compare those that relapse to those that never had surgery and had their diabetes continue to advance, they're much more metabolically healthy, and they perhaps are just back on metformin with very reasonable, but perhaps elevated A1C levels. So there's a metabolic memory component there that I think is not to be lost by saying that, that the remission is down to 50%. I'll also just say, parenthetically, when we look at adult studies, teenagers at 10 years are much more likely to be in remission, to remain in remission than adults. Adults after the same operation at 10 or 12 years have a relapse rate that's about 80%. So diabetes is one of those that I like to be plain and simple about the intervention and the outcomes of surgery, because my real message when it comes to diabetes is let's get to them sooner. Let's get to them before diabetes strikes. Let's get to them while they're pre-diabetic, where we can have a much, much better long-term metabolic outcome.
You're really good at helping me with my transition questions on this. So my next and final question for you is, we are very fortunate here at Lurie Children's to be able to offer our patients a program at Winfield, in our Winfield location, and downtown. With that said, and let's prevent from type 2 diabetes happening, when is a good time, or when should a PCP start reaching out to us for a referral and to start talking to their patients?
Yeah, so we talked a little bit about the age question, and from a weight standpoint, the guidelines do bear quoting here. The guidelines are really that when an individual, a teen or a pediatric patient, has achieved a body mass index of 120% of the 95th percentile, which is the way our pediatric growth charts are laid out now, and in the presence of a serious comorbidity of obesity, let's call it type 2 diabetes, sleep apnea, even hypertension on medications, things that we really do consider complications of obesity. So at 120% of the 95th percentile, which happens to correspond for teenagers who have achieved most of their adult stature to a BMI of 35, then that's appropriate for consideration for referral. Now, what about the patients that haven't yet developed a bona fide comorbidity of obesity? We are still working with the guidelines of 140% of the 95th percentile, or a BMI of 40. And perhaps that's too conservative, but that's what the guidelines currently state. And then certainly those that are marching toward abnormal glucose metabolism vis-a-vis a escalating or rising hemoglobin A1C in the 5.7 to 6.3 range, we really want to try to focus on early referral of them, even again at these hemoglobin A1C levels 5.7 to 6.3 that define prediabetes, because I think they have so much more to lose by not getting to us, and just really a lot to gain from having the surgery.
Thank you so much. That's a great answer, and great to hear that. As we are going to close off here, I want to remind everybody that to join us tomorrow for session 2, Dr. Angel will be joining us again, along with Karen Magarelli. She's our presenter, and she'll be talking about advanced therapies for children and adolescents with severe obesity. So we're moving our roundtable, and we're progressing along until we get to session 3, which is another great topic by Dr. Kelly Lowry. And she's going to be talking about the mental and behavioral health considerations for youth with severe obesity. So I encourage you to keep joining us for these sessions, but you will also find the recordings here on our Physician Services YouTube page, and you'll be able to find it on the playlist. Dr. Inge, I think you had something you wanted to bring up with us.
I did. I want to invite everyone to come register for CME or not, depending on what you like. But we all are welcome to visit us and attend the Surgical Care of Obesity and Pediatrics Symposium. We call it SCOPES for short, May 5th, 2026. It's an all-day event in the former ADA building right next door to Lurie Children's. We call it 211 East Chicago now. We would like to talk to you about the evidence. I will say I'm very proud of my research team that over the years has published our work in notable journals, including the New England Journal of Medicine. And so I want to bring good evidence-based care recommendations and experience to Chicago's community, the pediatricians and others that would like to attend. And I'll also just say that I'm very reachable at my Lurie email address, tinge@luriechildrens.org. If anyone would like more information, would like to dig in and find out if Dr. Inge is telling the truth and has evidence to back it up, I'm happy to send you any of the work that we've published over the years on any of the topics that are of interest.
That's great. And registration will be open soon. And if you are interested in the event, please reach out to us and we will provide you with the registration link and look for an invitation as well.
Well,
And then
thanks.
just lastly, I wanted you to point out that these are the referral phone numbers for our team.
Yeah, and I'll point out too that this is the entire team. This is on the far left, Irma, our nurse, Emily, as you've met today, Karen Mangarelli, again, a doctor of pediatrics, and is our medical director, myself, as well as Kelly Lowry, our psychologist, and Alyssa Williams and Annette Ortiz on the far right, is our program coordinator. Again, thank you for your attention today, and we look forward to taking care of your patients and working with you to get them back to a healthier adolescence and healthier adulthood as a result.
That's great. Dr. Inge, Emily, thank you so much for joining us today. And we look forward to session 2 tomorrow. Everybody have a great day.